HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
All those attending the various HealthEd conferences over the past year were invited to submit their burning questions to all the experts who presented at the conference. One of those speakers was Professor Rodney, who was one of my expert panellists in a hypothetical on menopause, and Rod is my special guest today. Rodney is Professor of Obstetrics and Gynaecology at the University of Sydney and heads the Menopause Hub at Royal North Shore Hospital in Sydney. He's a life member and past president of both the Australasian and International Menopause Societies. Rod is Editor-in-Chief of Climacteric, the Journal of the International Menopause Society, and is also the Associate Editor of ANZ, Journal of Obstetrics and Gynaecology. Hello, Rod, and welcome to today's HealthEd Women's and Children's Health podcast.
Hi, Terry, and thanks very much for inviting me. It's great to be here.
Now, when we presented the hypothetical on menopause at the recent series of HealthEd conferences, it seemed that the cases discussed raised almost as many questions as they answered. So it's really great to be able to put the questions submitted by the participants to you today, and hopefully we'll be able to clarify some of the issues that they raised.
Well, that's good. I think it's great to have the opportunity to do that because
Yes.
Usually we get to the end of all these things and questions could have gone for an hour, I think, sometimes.
Which is great that we're able to do it now. So thanks again for agreeing to do it. Now, determining the risks around MHT use was one area that really raised quite a few questions. So maybe we can get started there. And the first question somebody submitted was, does estrogen alone MHT increase the risk of breast cancer or ovarian cancer?
Yeah, that's a really good question, because if you look at any cancer society websites, they all say that estrogen alone may increase the risk of breast cancer or ovarian cancer slightly, and that the risk will go back to normal when you stop the hormones. The data we have, of course, comes from randomized clinical trials. And in those, in the Women's Health Initiative randomized clinical trial, the women who used estrogen for a bit over 7 years, estrogen alone, and then were followed for up to 20 years, had no increase in the risk of breast cancer, nor did they have any increased risk of death from breast cancer. So that's my position. I think we know that if women use estrogen alone for a reasonably long period of time, with long-term follow-up, the risk of getting breast cancer or dying from it is not increased. Mm-hmm. And I think the same is true for ovarian cancer. Ovarian cancer is a heterogeneous group of diseases. And so there is potential for estrogen to have effects on some types of ovarian cancer, but not on all types, and that's what's been borne out. So worst case scenario would be less than one case in 1,000 women per year.
That's a pretty low risk.
Yeah, it's very, very low risk.
Mm-hmm. Rod, someone else asks, how safe is menopausal hormone therapy in a woman with a history of migraine, with or without aura, and is any kind of MHT safer than another?
Yes, also a good question. We all know, I think, that the use of the combined oral contraceptive pill is contraindicated in women with a history of migraine, and particularly if they have aura. But there's very good evidence to show that the same risks don't apply to women who use menopausal hormone therapy. But we do recommend that transdermal therapy is the best option for delivering the estrogen. And the reasons for that are that transdermal therapy doesn't increase any risk of thromboembolic disease or stroke, but also transdermal therapy gives a much more stable serum level of estrogen, which means that the ups and downs that can trigger headaches are not seen with transdermal therapy, although they can sometimes be seen with oral therapy. And the other thing I'd say about using MHT in women with a history of migraine is that, of course, it doesn't always work, but sometimes, surprisingly, you need to use a slightly higher dose to get maximum benefit. So start low, start cautiously, warn your patient that she may well get a headache when she starts using MHT because her hormone levels will go up. But within a few days, they'll stabilize and she should be great after that.
Thanks, Rod. That really does clarify it. I found the next question really interesting because I think the whole issue about denser breasts is becoming, a bit topical at the moment. So this questioner asks, if a woman has dense breasts on mammography, is our only option Tibolone if she's postmenopausal, or no option at all if she's perimenopausal?
Yes, it's a good question, isn't it? Long ago, there was data published by a group in Sweden which showed that oral estrogen slightly increased breast density, that oral estrogen with a synthetic progesterone significantly increased breast density, and that oral estrogen with a progesterone containing intrauterine device only very slightly increased breast density. So my first comment is try to avoid using estrogen with a synthetic progesterone because that'll cause the most change in breast density. And secondly, of course, if you are using MHT, the lower the dose of estrogen, the less likely it is that it will have any adverse effects on the breasts, such as changes in breast density or mastalgia. So I would always start low, and I would just warn the ladies that they're likely to get a bit of a change in symptomatology initially, but that should settle. Whether it's perimenopausal or not, I don't think, for me, makes a great deal of difference, because in the perimenopause, hormone levels are all over the place. And in some cycles, the women will have high levels of estrogen and in other low. So again, I'd be aiming fairly low and trying to use body identical hormones where possible. Although, as we know, Tibolone does not increase mammographic density in postmenopausal women. And I suppose, Terry, the other option, if it was available, would be the TSEC, the combination of estrogen with a selective estrogen receptor modulator, not available in Australia at the moment. Did you want to comment on that, Terry?
No, but I think it's a question I think that's out there, and a lot of women are concerned about dense breasts. I guess the best information we can give them is that yes, they may be at slightly higher risk of breast cancer, and of course, the the fact that denser breasts make it harder on mammography to pick up a small breast cancer. But look, I think the advice you've given is absolutely right, because I don't think that we can drive our decisions on breast cancer risk alone. And I think that, you really have to, it's the same discussion we have with every woman, isn't it? Looking at the risks, looking at the benefits, and making informed decisions around those risks and benefits for that particular woman sitting in front of us.
Absolutely right.
But I think it's a good question, and it's certainly one that I think, is worrying people at the moment. I've got another one here, maybe another controversial one. It says, can you clarify the concerns regarding the use and the safety of the troches used by some hormone doctors?
Yes, of course. The issue that most clinicians, and certainly I have with troches, is that they're not regulated. Troches are compounded. In other words, they're made up by either the pharmacy which dispenses them or another pharmacy on behalf of the pharmacy which dispenses them. There's no oversight from regulatory authorities. And having once been a pharmacist myself, I can tell you there are occasional, very occasional visits by the authorities to see if what you're mixing up is actually accurate. So we're mainly concerned about the lack of any regulation on the compounding of the product itself, but also there is absolutely no data on whether these troches have more harmful effects on the breast or on the endometrium, whether they have enough effect on the skeleton, for example, to protect the bones. We just don't know because research hasn't been done. So I would certainly be advocating against the use of troches wherever possible and recommending strongly that all of our clinicians use government-regulated body-identical hormones where they can.
Thanks for that. I think that's great advice. The next questioner says, can you still use the combined oral contraceptive pill if you're a non-smoker but over 45 years of age?
Yes, the basic message here is in the absence of any other contraindication, you can continue to use the combined oral contraceptive pill until you are at the age of 50, whereafter the medical eligibility criteria that you can access from the College of GPs or from the Faculty of Sexual and Reproductive Health in the UK all say it shouldn't be used.
Great advice. Let's move on to some questions on investigations. So somebody asks, is it worth routinely doing breast ultrasound as well as mammography before prescribing MHT?
Yeah, that's a very good question because, of course, our screening services don't. They just do mammograms.
Mm-hmm.
So if we're guided by the recommendations of learned authorities that have planned our screening services, then my answer would be no. You only need to do a mammogram. I think the exception to that rule would be if the mammogram reports the breasts as particularly dense, and if you have any other concerns regarding this patient, then an ultrasound may be useful. It's certainly a useful investigation in premenopausal younger women because their breasts are denser, and the ultrasound enables you to see things like cysts that are not often visualized on mammography.
The next questioner says, at what period after commencing MHT would you investigate PV bleeding to ensure it's not due to endometrial cancer?
Sure, good question. So the short answers are, firstly, if you are perimenopausal and you're taking sequential hormone therapy, so estrogen all the time and a progesterone for 12 to 14 days a month, you should bleed towards the end of the progesterone phase, and it shouldn't be prolonged bleeding and it shouldn't be heavy. If it is prolonged, if it's heavy, or if it's out of cycle, then you do an ultrasound. If you're postmenopausal and taking continuous combined therapy, then it's quite common to have some breakthrough bleeding or spotting for up to 6 months. Beyond that point in time, you need to do an ultrasound to exclude any abnormal pathology. Now, the exception for that would be, of course, if the bleeding is becoming increasingly bothersome over the period of 6 months, then I would investigate sooner, because most of the time it should become less and less.
The next questioner asks, how long after a Mirena is removed are blood tests reliable for the diagnosis of menopause?
Well, a Mirena is not meant to make much difference to serum hormone levels or to FSH levels. So being a cautious chap, I'd say wait 1 cycle or 4 weeks, but that would be my answer. You could probably do it straight away, but I'd probably wait a few weeks just to be sure. Terry, what do you think?
I'm pretty happy to do them while they're on them. I think, it's a reasonable guide, given as much as, FSH, LH levels are only ever a guide anyway. So I would tend to do it on it and, and take that into account when I'm looking at symptoms and the age of the woman and, that sort of thing. I really think, Rod, that the main message that you're getting out there is an important one, that even though Mirena may stop bleeding, it doesn't tend to stop people ovulating. And so, you can in fact rely a little bit on the tests that you do, given the age of the woman and maybe her symptoms as well. Next question, Rod. One of my patients is now 48 years old and on her second Mirena that was replaced 2 years ago. She's had no vaginal bleeding for the last 5 years, and she's wondering if she's postmenopausal, no symptoms, and she's read about the importance of estrogen for bone and cardiovascular health. Is it worth doing FSH levels? Is there a role for estrogen replacement in this case anyway?
Yeah. You sure you didn't write these questions, Terry?
I promise I didn't.
They're great. So this lady's fortunate. She's not bleeding and she's on Mirena, and she has no menopausal symptoms and she's 48. So using the law of averages, she probably isn't menopausal. But it is true that if we talk about the stages of reproductive aging as described in Straw Plus 10, but they do not apply to somebody who has a Mirena in situ or has had a hysterectomy or has had an ablation. So I don't think an FSH is necessary in this woman, but if she's concerned, then I probably would do one just to see if she had reached the menopause or not.
I think that's a great idea. And, maybe if there are concerns about her bone, this might even be a case for doing an early bone density study, perhaps.
Yeah, indeed.
Rod, how long does a woman have to have ceased the oral contraceptive pill before you can accurately measure FSH, LH, and estradiol?
My opinion is 4 to 6 weeks. 4 to 6 weeks.
Because a lot of people measure it during the pill-free week, don't you? That's not enough?
No, look, I have Actually, when I was a registrar, I could remember reading old textbooks that said that. But my experience has been that it takes longer than that for things to actually be reliable. So I wouldn't do it in the sugar-free interval. I'd really have a break and measure everything after about 4 weeks.
Sounds like great advice. The next one's on levels as well. It says most labs only give an estradiol level as a range, and if it's low, they will say less than 100. Can we request a more specific level, or is there a special lab you could recommend to do this?
Well, it's usually done for research reasons. By and large, we would accept that the menopause was a level less than 100. We might perhaps be more concerned about the level below that if, for example, a woman was on aromatase inhibitors. But generally speaking, we would say that a level less than 100 was predictive of the menopause and no need to do more than that. But research laboratories would probably be able to get you lower levels if you really need them.
Rod, when you're requesting hormone panels, the questioner says, my lab always lists FSH, LH, estrogen, and progesterone. Are all of these necessary when you're talking about menopause?
No, they're not. For a start, when you're menopausal, your ovaries are not working. So there's going to be no progesterone. The estrogen will be low. The interesting thing about the first two, FSH and LH, is that FSH goes up before LH. So if we are looking for predictors of menopause, it's a raised FSH. And we would normally say, for example, for somebody in whom you are suspicious of menopause, 2 levels of FSH in the menopausal range, 4 to 6 weeks apart, is diagnostic. Sometimes, if you're uncertain, you could do an estrogen as well, but that's much less reliable. The FSH is the critical one.
Thanks for that. That's really important info, I think.
This episode is one of hundreds of informative and free clinical podcasts from Health Ed. Access the entire library through the Health Ed app for healthcare professionals, which you can download today from the App Store.
Now we come to the thorny area of treatment decisions. How long after the last period, this questioner asks, can you safely start MHT?
Okay, so until you are 1 year from the last period, you're perimenopausal. So my answer, first of all, is it depends whether or not your patient has symptoms or another indication for you to prescribe MHT. The principal indication to use MHT would be to alleviate troublesome menopausal vasomotor symptoms. So if she doesn't have those, you do not need to start MHT in the perimenopause and maybe not even in the menopause. If she has osteopenia, however, or if she's had a fracture and you're concerned about bone health, then you may want to consider starting MHT a bit sooner. And if that's your indication, or if she has flushes, you can start MHT as soon as it is clinically indicated after the last period, remembering you would use it sequentially for the first 12 months, and thereafter, in general, if the uterus is intact, continuous combined therapy.
Next questioner asks, it says, the definition of menopause for the safety of stopping contraception is 2 years with no menses. If a woman is taking cyclical MHT, then she might still have regular bleeding, and I find it difficult to advise them when it's safe to stop contraception. Can you please advise?
Well, when we're talking about stopping contraception, we would recommend that if the menopause happens before the age of 50, contraception is continued for 2 years. And if the menopause occurs after the age of 50, contraception is continued for 1 year. Now, if your patient is postmenopausal and she is taking cyclical or sequential MHT, then she should have a regular withdrawal bleed at the end of the progestogen phase in every cycle. If she has no other bleeding than that for 12 months, it's very likely she's postmenopausal, because most women, if they are still having some endogenous hormonal activity, will have a small amount of bleeding from time to time, which is not what she is having in this description. So I think if she's had a regular withdrawal bleed for 12 months, I would probably be happy that she is postmenopausal. Then the question is, how long has she been postmenopausal? And once again, I mean, there is no, Terry, I will ask your opinion on this, but my feeling is there is no correct answer here, because whenever we measure an FSH, it's only reflecting what's going on that day. It's an unreliable test on its own. So I would probably think if she hadn't had anything except my provoked withdrawal bleeds for a year, I'd be happy. But maybe if I was in any doubt, I'd do an FSH and repeat it 6 weeks later.
I must be cautious. I do the FSH, and if it's suggestive of menopause, then I don't repeat it. I just say, just use it for another 12 months.
Right, right.
And if she's 55, I say, look, it's unlikely, but, if you're still getting regular bleeds, maybe we should still follow the same pattern. But it's interesting, isn't it? Because there often aren't hard and fast guidelines out there. Sometimes you do have to, make the best decision with the information you've got in front of you. And it's always confusing me that our definition of menopause is all around periods. And yet we're very often doing things that make it difficult to work out when that last real period actually was.
No, I agree. I say to my students at the university, we talk about periods all the time, but in fact, what we are actually talking about is the end of ovarian hormonal cyclical activity. That's the key. And sometimes we do not have a simple test that tells us exactly when that's happening.
Going to the other end of the spectrum, this questioner says, is there a maximum duration of MHT use? I hear conflicting advice around women in their 70s who are still using combined menopausal hormone therapy.
Sure. You'll never hear it from the women in their 70s who are still using it because they love it.
Yes.
But the current guidelines are that you should initiate hormone therapy. Once you've initiated, you should see your patient relatively soon after you initiate therapy to make sure that she's happy with what she's using and that it's doing what she wants it to do and that there are no problems. And then she should be reviewed on an annual basis. There is no mandatory stopping time. And if every year her symptoms and her other health issues indicate she should continue MHT, then that's okay. What you have to do with your patient is discuss the benefits for her individually compared to the risks for her with continuing. And you may need to change your doses of hormones over the years, and you may need to change the way you deliver the hormones. For example, as women get older and into their 70s, I'd want them to be on transdermals to reduce any thromboembolic risk, but no mandatory stopping time.
Thanks, Rod. This questioner says, I know you can use Mirena with estrogen for MHT. Can you also use other progesterone-only contraceptive methods like Depo, Implanon, or Slinda for both endometrial protection and for contraception?
There's no data on Depo and there's no data on Implanon. And unfortunately, there's no data on Slinda. But we do have a model for Slinda, which is a form of postmenopausal hormone therapy, which contains 1 milligram of estradiol and 2 milligrams of drospirenone. And that's been shown to be completely safe from the point of view of endometrial protection, but not for contraception. What we know with Slinda is it's an excellent contraceptive, and it's 4 milligrams of drospirenone. So I would be very comfortable adding a low dose of estradiol to the Slinda to alleviate the symptoms of the menopause. That won't affect her contraceptive efficacy because that's being derived from the progestogenic effect of drospirenone on GnRH pulsatility and also on the endometrium and tubal motility.
Yeah, I think it's interesting. I know the college in the UK, I think, has answered this question for us all, and they actually acknowledge that absolutely, but say there's no safety data. And they often recommend that we use the progesterone methods that aren't licensed, but add back some combined MHT.
Right.
So add back a combined patch or something like that, which, so yes, you're on contraception and you're on menopausal hormone therapy.
That's very interesting. Because somebody told me the other day they'd been to one of your talks and you'd said that that was what you did. And I didn't know why.
That's why.
That's very interesting. Yeah.
But the other interesting thing about Depo is I remember reading many years ago that Depo in itself can sometimes stop hot flushes, even on its own. and it was often
Well,
used
it's a fair bit, yeah.
but, not that we're recommending depot in women of this age much anyway. So
No, we're not.
okay, our next question is also on the pill, and it's for perimenopausal women being treated with OCPs like Zoli. What dose of estrogen, be that oral or patch, would you recommend during the pill-free period to control her hot flushes?
Sure. Well, Zoli contains 2 milligrams of estradiol in each pill. So I'd use a 2 milligram oral tablet if that's what the patient preferred, or I'd use a 50 microgram patch.
Perfect, easy peasy. The next questioner says,
Mm.
what is the role of catapress in the management of menopausal hot flushes and how effective is it?
Cataprase is an alpha adrenergic agonist, and which was first used, of course, to treat blood pressure. But in low doses, it's been shown to be moderately effective in alleviating menopausal vasomotor symptoms. Its efficacy is around about 60% compared to placebo. It's not as effective as SSRIs, SNRIs, gabapentin, or oxybutynin. But for some women, it is an option. Low dose tablet taken usually twice a day.
Sounds perfect. Rod, can we start testosterone in women under 50, maybe under 45? Is it just for low libido, or could it help with other symptoms like a lack of energy or brain fog or confusion?
Well, there's a position statement on the use of testosterone therapy in women, of which I'm an author. And we thought that, in our view, it should be limited to women who were postmenopausal, and it should be used for the treatment of hypoactive sexual desire disorder, which is a loss of interest in sex, which the woman herself finds distressing. The International Society of the Study of Women's Sexual Health also has a guideline published which says that probably for late perimenopausal women, it would be appropriate to use testosterone as well for the treatment of, again, low libido or hypoactive sexual desire disorder. So that's pretty much it. The interesting question that I can't or won't answer today is that are there other benefits of testosterone? And that's the subject of quite a lot of ongoing research. We certainly see with women who are prescribed testosterone for treatment of low libido that the first things they notice are a little bit more energy and a bit more get-go before they actually notice any change in sexual responsiveness. So I suspect it is useful for that, but it's not indicated for that. And at the moment, I don't think you should use it for those indications.
So the studies are being done.
Studies are.
And we need to stay tuned. Excellent. And the next question, Rod, is why is micronized progesterone recommended to be taken for 25 days of the month when you're using it continuously? Is it really necessary to stop for a few days, or is it safe to just take it every single day?
Good question. It's not necessary. It's recommended because when the original trials were being conducted to assess the efficacy and safety of progesterone in menopausal hormone therapy, a small study showed that there was less breakthrough bleeding when women used the progestogen for 25 days a month. And the reason for that is it gives them 4, 5, 3 days of estrogen alone, which gives the endometrium a bit more stimulation. And so you more or less eliminate bleeding from a very thin atrophic endometrium. My problem with that is compliance. And I suppose with modern devices like mobile phones, you can set them to know which 5 days you stop. But I've always been concerned that if women stop on day 25, they'll forget to start again. And so I've always encouraged women to use them every day. And I haven't had any problems. Well, I haven't heard of any problems related to excessive breakthrough bleeding or other side effects. Safe to take it every day.
And I don't think anybody's recommending a 5-day break, really. It's just on the packaging.
No.
And lastly, Rod, there are a few questions asking for some specific advice on a few cases, though I guess I should clarify that without having access to the patient's actual notes, any advice that you'd be giving should be regarded as general only. But let's go for it. Rod, the questioner writes, my patient was treated with chemotherapy for non-Hodgkin's lymphoma in her early 20s. She required right oophorectomy and the reasons not stated, and went on to have 2 children post-treatment. She's now 35 years old and she's had no periods for the last 4 months, and she's experiencing hot flushes at night. Her FSH was around 28 on one occasion. She has a normal prolactin, normal TSH, and a negative beta-HCG. A pelvic ultrasound indicated a dominant ovarian follicle and a thin endometrium. She's not taking any exogenous hormones at the moment. So I'm asking about the next steps. Should I refer her for tertiary care, or can I manage with menopausal hormone therapy, maybe the oral contraceptive pill, and some regular DEXA scans? Would you do additional screening, such as screening for Fragile X? The only symptoms apart from the amenorrhea at the moment are now the hot flushes. She's got no desire for future pregnancies, so does she still need contraception?
Well, she's almost certainly has premature ovarian insufficiency. She's amenorrheic, she's 35, and she's got an elevated FSH on one occasion. The definition of POI is 2 elevated FSH levels, so I'd do another one. It's good that you've done the prolactin and the TSH and the pregnancy test. That's very important. The ultrasound is not surprising because at this stage of her POI journey, she is likely to have an occasional period, and she is likely to have, therefore, an ovarian follicle. Her FSH might go up and down a bit occasionally, but gradually it's going to go up and stay up. The thin endometrium is good. The only, I think, thing there is we know that quite a significant number of young women with POI do have more periods after their diagnosis, but some get pregnant. Just a small number, somewhere between 1% and 5%. So you certainly do need to think about contraceptive methods for her moving forward. If you're confident, I don't think she needs tertiary care. I think whilst we've said this is almost certainly POI due to the chemotherapy for the non-Hodgkin's, it's a good idea to exclude other underlying causes. She may have been screened for Fragile X when she was pregnant, and if that's the case, you don't need to do that. But I'd probably, for the sake of completeness, certainly look at autoimmune disease, autoimmune thyroid antibodies and adrenal antibodies in particular, just to exclude other well-known causes. If she hasn't had Fragile X done, I'd do that. So contraception, a few more tests, and in terms of managing her cardiovascular and bone and mental health, we normally say that menopausal hormone therapy is first line for POI sufferers. But if she would prefer to use the combined pill and you feel she's going to be non-compliant with MHT, then the combined pill is fine. But what you need to do is skip those sugar pills. We don't want her having 4 or 7 days every month without any hormones. And then follow her up closely. Bone density, metabolic screens, and so on, and follow her, I think, several times in the first year, and then at least annually.
Rod, the next patient is in her mid-40s, and she's got a higher risk of osteoporosis, apparently, given her family history and her own hypothyroidism. She's used a Mirena for contraception for the past 3 years, and she's had no vaginal bleeding since just after it was inserted. She has no hot flushes or other menopausal symptoms. Rod, would you recommend adding estrogen therapy for the prevention of osteoporosis? If you do, what would you suggest and how long would you continue it?
Well, mid-40s, so she could be perimenopausal, but I think she has no symptoms of the menopause, so I probably wouldn't add estrogen straight away. I'd like to know that her thyroid disease was properly controlled. I'd like to know that she'd had a baseline bone density and what that was. I'd like to know what her markers of bone turnover were too, probably. And if I was worried about the need to give her estrogen, I probably would do an FSH, Terry, and if it was raised, I'd repeat it. And if it was raised twice, then I would look at giving her hormones. But otherwise, I wouldn't. I'd review her on an annual basis, but we have no sort of signals that she's going through the menopause at this stage, and the Mirena's been very effective.
The next patient is 55 years old. Her last period was at age 42, and she was on menopausal hormone therapy for 6 years, transdermal estrogen plus prometrium continuously. She had osteoporosis diagnosed at age 50, and at age 53, she had an episode of postmenopausal bleeding and was referred to a gynaecologist for advice. She underwent hysteroscopy and curettage, and a benign polyp was excised. She was then seen in a menopause clinic, and they recommended a Mirena insertion and increased her estrogel to 3 pumps a day. That was 2 years ago. And 12 months ago, she decided to stop her estrogen. She's adamant that the gynecologist told her that the Mirena was protective against bone loss. The doctor says, I disagree, but have I missed something? She's reluctant to restart because she's got no symptoms. A repeat bone mineral density was minus 2.4. I'm inclined to manage her conservatively with diet and lifestyle and not restart her estrogen and maybe monitor the BMD in 2 years' time. Is that reasonable?
Well, first of all, the Mirena isn't protective against bone loss. That's a furphy.
The doctor was right. Yes.
The doctor was right.
And
the
gynecologist wasn't.
Correct.
Or there's been a misunderstanding, I guess, is the other possibility.
Yeah, perhaps that's true. The interesting question is whether you could manage that conservatively. I wonder why she doesn't want to take estrogen again.
Mm-hmm.
That's the tricky thing. So once again, I think I would like to know when the last bone density was done, and I would like to know what those levels were in terms of T-scores compared to the previous one, because she's diagnosed with osteoporosis at the age of 50, and now she's got a T-score somewhere, I'm not sure if it's spine or hip, of minus 2.4, which is actually osteopenia. So her bones may have improved as a consequence of the hormones, and unless she was strongly against resuming therapy, I would be inclined to treat her with hormones and monitor her again in 2 years after appropriate treatment. I think what she has to understand is that if she doesn't continue with hormone therapy at this stage, then certainly within 2 years, she's going to need something to treat her bones and therefore most likely treat her osteoporosis. And that would either be more hormones then, or a bisphosphonate or a rank ligand inhibitor. And most likely, given what we know today, I think most clinicians on a woman in her 50s would use a bisphosphonate ahead of a rank ligand inhibitor because of all the issues we have if you stop a rank ligand inhibitor after 5 years or so. Sudden loss of bone and a bit difficult to get it back. So I think you need to have a look at the bone densities and see which way the bone was going. You need to talk to the patient and see why she really doesn't want estrogen, because estrogen is an excellent first-line therapy to protect her skeleton, and it's saving her from having to deal with using another more potent bone-sparing agent, which has, of course, side effects of its own earlier than she might need to.
I'd be tempted in this case, Rod, to maybe enlist the help of a friendly, tell it as it is, endocrinologist maybe, to sort of lay that out and maybe get a bit of backing for some of the messages I'd be trying to deliver.
That's a fair point.
Thanks so much, Rod, for answering so many of those questions today. But I know there's always going to be more. Do you have any good websites that you might recommend to our listeners or to their patients that you think might be of help in answering some of these questions?
I do, Terry. First of all, let me say it's been an absolute pleasure and quite challenging too. I can see why my colleagues have had trouble with some of these matters, because there are some very interesting issues that have been raised today. I would strongly recommend the Australasian Menopause Society website. It's outstanding. It has a great deal of information on the site, and you can also, via that site, access information sheets on almost every aspect of menopausal and perimenopausal health care. Gynaecologist for Women is another excellent site, and similar information is available at Gynaecologist for Women as for AMS. So for Australian colleagues, they would be, for me, the most two important sites available.
And I'm going to do a bit of shameless promotion for you, in that I know that Health Ed's got some great menopausal educational things at the moment, which you star in. And I've looked at them and they're amazing. So I would also recommend that everybody goes and has a look at that. They're absolutely amazing. So thanks, Rod, for sharing your time and your expertise with us all today. It's been a joy. It's been great to pick your brain on such an important topic, and it's given me a whole bunch of ideas for next year's hypothetical. So thanks again. Take care.
Thanks, Terry. It was lovely. Nice to talk with you. Bye.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.